Hello everyone. Today we'll talk about chapter 23, the child with a sensory and or neurologic condition. So ears, we did talk about the segments of the outer, the middle, and the inner ear. For the outer ear, so you have your in page 539, you can see that picture and it's actually telling us the names of the parts of the ears. For the outer, you have your auricle, your pinna, and then the external auditory canal, all the way up to your tympanic membrane. From the tympanic membrane, you have your middle ear that actually includes your ossicles, those little bones in the middle ear. They are malleus, incus, and your stapes. And then you also have your eustachian tube. From there, you have your inner ear, which is the one with the semicircular canals. And again, you can see it in your picture in your 539, page 539. And then also we did talk about the function of your eustachian tubes. So it's ventilation, protection, and the drainage. Ventilation of the middle ear, it helps with ventilation of the middle ear. And then protection from the nasopharyngeal secretions, and also protection when there's like a change in the pressure from the outside to the inside or the middle ear pressure. That's why I mentioned yesterday that when we go, for example, when you're in an airplane and it's like ascending, so the pressure is actually changing between the outer and the inner. So that's why they're like saying, oh, you have to like yawn or you have to like chew gum because it helps with opening up that eustachian tube and helping with the pressure. Another function of the eustachian tube is the drainage. So we did talk about the eustachian tube being connected from the ear, from the middle ear, going down to your throat. So if there's like secretions from, from that middle ear or from the nasopharyngeal, that eustachian tube can actually help with drainage. Okay. All right, so for the newborn, their tympanic membrane are almost horizontal. It's very straight, right? It's more straight comparing to adults. It's also shorter, of course, compared to adults. They are more vascular. And when you look through it with like an otoscope, there will be like an inconsistent light reflex. And again, like I said, tube is shorter and straighter than in adults. So the first condition is your otitis externa, which is an acute infection of the external canal. Like I said, if you look at page 539, you're going to see that little area in there, which is the external auditory canal. That is the one that is actually affected when you have an otitis externa. And this one is often referred to as the swimmer's ear. Why? Because with otitis externa, the most common cause is exposure to moisture. So prolonged exposure to moisture is often the precipitating factor. So like what are the manifestations for your otitis externa? There's going to be a pain and tenderness when you are manipulating the pinna or the tragus. However, when you look, the tympanic membrane is actually normal. It's not going to be red. It's not going to be inflamed. There's not going to be any drainage. So tympanic membrane will be normal. And before the child is actually diagnosed with otitis externa, the first thing that we need to do is to rule out anything else that actually can cause the pain and tenderness of the external ear, like your presence of a foreign body, cellulitis, diabetes mellitus, or even herpes zoster. Ruling out the presence of a foreign body, it's very common for little kids to be putting toys or foreign body in their, maybe in the ears or in the nose or in the mouth. So that's why we rule those out first before we say, oh yeah, it is an otitis externa. So how do we treat it? Well, if it's caused by bacteria, then we use a topical antibiotics. If it's caused by virus, then you use an antiviral. If the external canal is actually blocked, for example, then you need to have some kind of irrigation to open up and clean that area. But before we move forward with the otitis media, for your otitis externa, I did mention the use of what we call a wick. So with wick, you actually have that loose cotton gauze that is inserted in the outer third of the ear canal. And the wick is actually the one that will keep those medication, the drops that you're gonna put in there, and keep that medication in that area and keep that area medicated. Versus if you just put the ear drops in there and then the child will start running around or move a lot, then there's a risk that that medication is not actually going to stay in that area. Okay. All right. So next up is your acute otitis media. This is the inflammation of the middle ear. So what are the structures of the ears that are affected with your acute otitis media? It's the middle ear, which is your ossicles, your malleus, your incus, your stapes, and the eustachian tube itself. The problem with this one is because the eustachian tube is affected, so the infection in the middle ear can actually spread to the throat and even go down all the way to your lungs, and vice versa, right? If you have like a respiratory infection, for example, or infection in the throat, um, that one can also travel all the way up to your middle ear and can cause otitis media. So the middle ear, like we said, is lined by mucous membranes. There's the mastoid sinuses is in there. And this is more common in secondhand smoker children, more common in children that goes to the daycare, and those children that actually has like increased exposure to other children. It's common in secondhand smoker children because of the effect on the protective cilia, which are those hair-like structures in the mucous membranes. So when those are being destroyed because of the secondhand smoking, then the risk of having that infection actually increase. So acute otitis media is usually caused by various organisms, but the most common cause is your Streptococcus pneumoniae and your Haemophilus influenzae. And for this reason, we usually recommend for children to have vaccinations, your pneumococcal polysaccharide vaccines, because it helps reduce the incidence of acute otitis media that is caused by those bacteria. However, those vaccines are not effective in children less than 2 years of age because they are not mature yet to have those antibody response. In addition to those patients or children that I mentioned that are high risk for this condition, infants are also at high risk for this because of the mere fact that their eustachian tube is actually shorter and more straight. And this is why we don't recommend for parents to prop those bottles for your children or leave them laying down with that bottle or of milk that is actually just pulling down and is actually going to the ears because it put them at high risk for infection, your acute otitis media. Okay, if that infection actually occurs for more than 3 months, then this is considered as chronic otitis media. Again, if it's more than 3 months, then we consider it as chronic otitis media. Very, very important for us to address this infection right away because recurrent attacks can lead to serious complications like effusion or fluid accumulation in the ear, or those what we call cholesteatoma, or those cyst-like sac in the ears, or even hearing loss. It can cause hearing loss. What are the manifestations of your acute otitis media? Very severe pain. The pain is so severe that the children might just be very irritable, will be for crying so much because of the pain. Maybe you're gonna have a child that is going to have some tantrums because of it. But yes, the main manifestation is very severe pain. And then the child will also have a fever, a high fever that can actually go up to 104. And with that fever, the child can actually be at risk for what we call febrile seizures, or those seizures that actually goes together when the fever is actually high. More signs and symptoms is your headache, vomiting, and diarrhea. Other signs and symptoms. So for those children or infants that cannot actually communicate that very severe pain, then it's going to manifest as maybe rubbing or pulling at the ear. They will have some rolling the head from side to side. They will start talking loud because that hearing problem is actually going to start. Inattentive behavior, maybe talking like articulation problems, and then speech development problems will also be signs and symptoms. Management and treatment, we usually give them oral antibiotics because like I said earlier, it is commonly caused by the Streptococcus pneumoniae or your Haemophilus influenzae, which are bacteria. So that's why we give oral antibiotic, your oral amoxicillin for 10 days. And then if it becomes really severe, that there's so much pressure, then they're gonna have what we call myringotomy, or your eardrum incision, where they're gonna have to like put a little incision to kind of like relieve the pressure. We give them antipyretics for the fever, so we can control the fever. Like I said, it's high fever that could go all the way up to 104. Warm or cold compress can also help. The cold compress can actually help to reduce the edema and the pressure, while the warm compress can actually help with the pain and to give some comfort. If the eardrum actually is affected and it's ruptured, then it's very important to remember that the child is actually going to be placed on the affected side to help with the drainage and to help with the comfort. Then we have what we call a tympanic membrane button, or your tympanostomy ventilating tube, or PE, your pressure equalizer. So this is like a little button, like a little button that is actually has a space in the middle. I mean, you can look it up and see pressure equalizer that we put in the tympanic membrane. If the infection is actually chronic, then we go and use this as a part of management and treatment. What it does is, like the name itself is saying, pressure equalizer. It's helping with balancing that pressure between the middle ear and the outer environment so that it can help with pain and the comfort that it will give to the child. That pressure equalizer tube or PE tube, it may fall out within 6 to 12 months. So that's why we may need to reinsert this, because remember that we are dealing with little kids. So the patient is actually still in the process of growing and development. So that's why when you put something like this that goes actually and implanted in the tympanic membrane, chances are it's going to fall out. And we are going to need to reinsert a new one every few months. Okay. Follow-up appointment is very important to see if the condition is actually resolved, and also to have the child have a screening for the hearing, because one of the adverse effects of this condition is actually hearing loss. So we want to make sure that we're preserving the sense of hearing of the child. So that's why follow-up appointment is very, very important. Okay, hearing impairment. So hearing loss can result from defects in the transmission of sound to the middle ear, maybe damage from the structures, the ear structures itself, and the nerves, the auditory nerves, or a mix, loss of both, a defect in the nerve pathways, and the interference with the sound transmissions. You have the classifications of your hearing aid, which is what we call either congenital or sensory neural, or even conductive. So what are the difference between them? Congenital is from genes, from hereditary, or an infection that actually started while the baby is still inside in the uterus, so uterine infection. Low birth weight can actually cause congenital hearing impairment. Prolonged resuscitative measures. So maybe, the baby is actually sick when it came out from the uterus, and then there's like resuscitative measures that we need to do for the kid. Then prolonged resuscitative measures actually can cause this. Low birth weight, if I did not mention it yet, um, those are the things that can actually be classified as congenital hearing impairment. Sensory neural, this is when those hair cells, your hair cells along the cochlea and the acoustic nerve may be damaged from maybe some toxins like environmental toxins or even genetic anomalies, and the exposure to loud noises. Okay, that's sensory neural. For your conductive, the tympanic membrane is preventing sound from entering the middle ear. So it's very important that there's nothing that's blocking the tympanic membrane for that sound to be entering to the middle ear. If something is blocking the tympanic membrane and preventing that sound from entering from the outer to the middle ear, then that's what we call conductive hearing impairment. So what are the examples? Maybe an impacted cerumen, right? Your cerumen. Maybe a perforation itself of the tympanic membrane, or maybe it's inflammation or infection. Those are the things that could cause that conductive hearing impairment. So how do we diagnose hearing impairment? We diagnose this by doing hearing tests, of course, before discharge, after the mother give birth to the baby, and then you do a hearing test before discharging the patient, and or before 3 months of age. So you do that hearing screening, and then when they go back for the follow-up appointment, then that's when you would do those hearing screening again. So behavior problems may arise because children do not understand verbal directions, so they get frustrated because they cannot communicate properly. So the child might actually have some tantrums. They might actually act out, those behavior problems because they don't know how to properly communicate because of the hearing impairment. So interventions is very important and should start right away, no later than 6 months. We try to catch it as early as we can so that intervention can actually start right away. And when we do those diagnostic testings, then you're going to see that the child actually will have like a lack of response to music and noise. Those startle reflex or your Moro reflex, right? In infants that's less than 4 months, around this time, your newborn should have a Moro reflex or the startle reflex. And if they don't have it, then you're gonna say, oh, yes, maybe there's a hearing impairment. Because in order for them to have that or elicit that reflex, you're gonna have to like maybe do a loud noise so that the baby will be startled and they're gonna show you that reflex, right? So if they don't have that, then you have to rule out hearing impairment. Okay, so now some cases cochlear implants actually help. So there's gonna be like implants that could help and manage with the management and treatment of the hearing impairment. But one thing to remember for nurses, those patients that's actually going for cochlear implants, please make sure that before the surgery we give the child pneumococcal vaccine before the surgery. We give pneumococcal vaccine before the surgery because this is preventing complications that could be related to bacterial infection. Okay, again, those children that is actually gonna go for cochlear implants to manage their hearing impairment, make sure as the nurse that's taking care of the patient, you give the pneumococcal vaccine before surgery to prevent complications related to the bacterial infection. Okay, when addressing a hearing impairment child, the nurse should remember these things. Be at eye level with the child. Okay, the child needs to see your face, to see your mouth or your lips, sorry, so that they can actually understand what you're trying to tell them. Be face to face with the child. Okay, establish eye contact. And then when you talk to them, you talk in short sentence. Do not be just blabbing out words while you're talking to a child with a hearing impairment. Otherwise, they're not gonna understand what you're trying to say, and then there's going to be an impaired communication between you two. Avoid using exaggerated lip of face movement. Yes, you don't have to exaggerate the movement of your face or the movement of your lips. All you need to do is to make sure that the child can actually see you eye level. There's gonna be an eye contact, and you are talking in short sentences. Okay, barotrauma. This one is an injury that occurs when the pressure in the atmosphere between a closed space and the surrounding area changes. Like one example I already gave earlier is your airplane descent, or also your underwater diving. Okay, so again, your barotrauma is actually the injury because of the pressure in the atmosphere between the closed space and the surrounding area space. Okay, so for example, for your airplane descent, what can we do to help? Like I mentioned earlier, yawning can actually help, chewing gum, or for children, maybe sucking on a bottle will help to prevent this. Um, Also, studies have shown also that decongestants can actually help. Decongestants can be taken, but it's recommended to take it at a time to ensure that by the time that you're actually going to be exposed to that pressure, the medication's effect is actually at their peak, um, so that it can help. If we're talking about the pressure change with the underwater diving, what we can do is to educate them, the descent should be slow, right? The change in the positioning is actually slow so that it allows the more time to equalize the pressure. Sensory hearing loss and vertigo with nausea and vomiting, those are like early signs of the decompression sickness. Another thing to remember is whenever the child or the patient had an upper respiratory infections or the perforation of tympanic membrane, those things are actually contraindicated to diving because combining those two things, having an infection, upper respiratory infection, or the perforation of the tympanic membrane, combining with the diving, it will cause vertigo, nausea, and vomiting, even disorientation. And these things can actually occur with very dangerous results. Okay, so we're done with the ears. Let's talk about the eyes and the conditions that actually affect the eyes, but focus still on the pediatric population. So the eyes begin to develop in a 4-week old embryo, and then the newborn sign is actually not mature yet. It's actually the visual acuity is estimated for newborn in the range of 20 over 400. 20 over 400. That means that whatever a normal eye can see in 400 feet, that newborn can actually see it if they go closer up to 20 feet. So it's 20 over 400. The shape of the eye is less spherical in newborn. Tears are not present until 1 to 3 months of age, and then depth perception does not actually begin to develop until about 9 months of age. And this is why this is usually the time for children to actually be able to stand up and like take some few steps because of the depth perception. Dyslexia is a reading disability that involves a defect in the cortex of the brain that processes graphic symbols. So in a normal situation, for example, I'm looking at this word dyslexia, and the letters I'm looking at are Dyslexia. And what my eyes are looking at, the brain is actually interpreting it and saying, yes, the D is next to the Y, the Y is next to the S, and it's read as this. And Lexia is Lexia, right? That's in a normal situation. So for children that have this reading disability, whatever they're looking at these symbols or they're looking at these letters, and yet there's a defect in the brain, and the brain is not processing it properly, and that's why they cannot read. So how do we treat this? Treatment involves remedial instruction, meaning that you're going to have to keep retraining the child, hoping that that brain can actually be trained to look at the letters or the graphic symbols, and hopefully eventually the brain will be able to process it and interpret it. Okay, amblyopia. Amblyopia is actually a reduction or loss of vision that usually occurs in children who strongly favor one eye. We call this the lazy eye. Okay, this is called a lazy eye. How do we treat it? Treatment, we use glasses, and then or we can use those contact lens or patching the good eye. What you're trying to do is by patching the good eye, you're actually forcing the other eye, the affected eye, the weaker eye, to be used. And by using it, is actually exercising that eye to be stronger. Okay. Um, Another option that we can do is the atropine eye drops. It's an eye drop that actually helps to blur the vision. So you put it in the eye, and because of the blurred vision of that eye, the other eye is now actually forced to work more in order to see. So it's the same concept as patching the good eye, only that this one is actually an eye drops, atropine eye drops, to help blur the vision of the good eye. The only problem with this is that what if you're dealing with a school age child or maybe an adolescent? So they are very self-conscious. So they're not gonna want to go to school or go to the public wearing a patch, an eye patch, right? But also the problem is that that's a better option than doing an eye drops. An eye drops, especially an atropine eye drops, there's going to be some side effects, and we don't want that. So that's why patching the good eye is always the first go-to of treatment. Um, and then glasses or contact lenses. But if we really need to, then yes, there are option of also using an atropine eye drops. Strabismus. This is also known as cross eye. So for strabismus, there's several types. You have your non-paralytic and your paralytic. What are the difference? The difference is that for your paralytic, it involves a paralysis or weakness in the muscle of the eye, the extraocular muscle. Okay, your paralytic involves a paralysis or weakness in the extraocular muscle, where the non-paralytic actually is just a constant deviation in the gaze where the one eye always looks like it's crossed. With your paralytic, the deviation of the gaze occurs with movement when the eye is actually attempting to focus. Child is not able to direct both eyes in the same direction. That's why it's called cross eye. And there's a lack of coordination between the eye muscles that direct movement of the eyes. When that coordination does not occur, the brain will disable one eye to provide a clear image. Isn't that cool? Right? The brain and the eye is trying to like coordinate with each other. And with your cross eye, if that eye, one eye is actually not helping the other eye, the brain is now going to shut down or disable one eye so that the other eye is the one that's working, and it can provide a clearer image. However, the problem with that is that the disabled eye can develop permanent visual impairment because of the sensory deprivation. Okay, to prevent double vision, the child actually may, you will see that the child may actually tilt their head or even squint their eyes. So those are like manifestations that you're going to see, is that the child may tilt their head or squint their eyes. For your paralytic strabismus, the visual exercises or surgery may be required to restore muscle balance, because this has something to do with a weak muscle of the eye. For non-paralytic, we can actually use eyeglasses. And then for both for strabismus, they may be present either at birth or maybe after a disease or an injury. It could also be caused by a head trauma, because of some cranial nerve damage. And if strabismus is not treated, blindness in the affected eye may result because the brain tends to obliterate the confusing double image by disabling the eye. So, if you're going to receive a patient or a child that just had a surgery involving the strabismus, the child is actually allowed to be up and about. Why? Because the surgery involves those structure that is actually outside the eyeball. So they are more than okay to be up and about. Okay. Eye dressing. Eye dressing is kept at a minimum. You don't want to like overdress that eye, and then next thing you know, both eyes are cannot see because of the heavy dressing that you put in the eye of the patient. So eye dressing is kept at minimum. Some instances, especially for those little kids, the elbow restraints actually should maybe used to help after the surgery. Eye strain. Eye strain symptoms, you have your inflammation, aching or burning, squinting, short attention span, frequent headaches, difficulties with schoolwork, and the inability to see the board at the front of the class. Nursing interventions for your eye strain. Observe. Right? The first one is to observe. Maybe it's the parents that will tell the clinician, or maybe it's actually the teachers in school that see the children um, every day, and they're going to see some signs of symptoms of eye strain. Maybe they're actually squinting, or they're saying that they cannot see at the back of the class, and they have to like move closer to the board. So um observe for your signs and symptoms so that we can actually have some early interventions for your eye strain. Teach. Make sure that we're teaching the patient and saying, for example, it's an adolescent, right? And there's like so many homeworks that they have to do. And um, they love doing those homeworks while the light is off inside their room in the corner. Then you gotta teach them and say, hey, to prevent eye strain, there are things that we can do. You make sure that you don't read when it's dark. Turn on the light, right? There should be an adequate light so that they can read properly, or they can look through books, or they can do whatever task, and the eye is not actually working harder just to see. um, Preventing it, refer, and rehabilitate if we need to. Preventing it is just the same thing as you're teaching with the patient. You make sure, to prevent eye strain from happening, make sure that you're actually in a well-lit environment. For example, if you're going to do a task, or maybe you're going to read a book. Conjunctivitis is the inflammation of the conjunctiva, or the mucous membranes that lines the eyelids. So these are those, pink mucous membranes that we look at when we do our assessments. That's the conjunctiva. If you guys recall, also, if you're gonna give like eye medications to patients, then it's the conjunctiva that you actually expose, and you put those medications in there. Okay, this one is caused by a variety of bacterial and viral organisms. That's one cause, right? It could be caused by a pathogen like bacterial or viral organisms, or from a blocked lacrimal duct. Okay, maybe that lacrimal duct is actually blocked, then it can cause inflammation of the conjunctiva. Acute form, we call this pink eye, right? Pink eye. Very highly contagious. Okay, highly contagious. Remember that it's caused by those pathogens, those especially those bacterial. Okay, common forms respond to warm compresses, topical antibiotic eye drops, or eye ointments. Okay, warm compresses. How can it help? It helps because those warm compresses can actually helps loosen the mucus and removes the crust, because conjunctivitis will have all of those drainage that's coming out from the eyes, and because it's an inflammation, it's an infection, there's going to be drainage, and it may even have those crusts in the eye. So warm compress can actually help loosen those mucus and helps removes the crust. So I did mention this is highly contagious. Um, like maybe in like inanimate objects, for example, you have the pink eye or the child has a pink eye, and then they kept rubbing and rubbing their eyes, the infected eye, and then touched a table, right? And then next thing you know, the sibling is coming in and touching the table as well, and then rub their eyes. Okay, so it's contagious, right? But please remember that if the child actually goes to a doctor or um, got some help, and the doctor actually ordered for that child to actually start an antibiotic therapy, then after they start that antibiotic therapy, 24 hours after, they are no longer considered contagious. Okay, the child is no longer considered contagious if it's after 24 hours have passed that they have been taking the antibiotic therapy. Uh, when we use those eye ointments, you want to make sure that you're using it at daytime. The order is for daytime for the patient because it is causing some blurring of the eyes. And of course, if you use it at daytime, then it's not going to help with the mobility of the patient. So that's why those ointments are not used during daytime. You prefer them to be given at nighttime when they're ready to go to bed or to lay down, and it's okay for them to have those blurred visions. If you're gonna give those eye ointment, we gotta remember that you're gonna pull that, you're gonna expose that conjunctiva, and then you're gonna give that medication from the inner to the outer canthus, and then you're gonna have, after you give that medication, then you're gonna have to give your patient some maybe some wipes, uh, and when they do that, we gotta make sure that they have separate towels or separate wipes for each eye. You don't want to be using same wipes wiping the affected eye, and then they're gonna wipe the other eye, so it's gonna spread right from one eye, it can spread to the next eye. Okay, if there's no prevent infection prevention that is being practiced. Hand washing is very important. Wash the hands frequently. And then if you guys recall what we call ophthalmia neonatorum, right? When we give those erythromycin ointment to the newborn, it's because we're trying to make sure or prevent things like your pink eye, your conjunctivitis. That is what we call ophthalmia neonatorum. And then we also have those allergic conjunctivitis, like those hay fever. Okay, they can also cause conjunctivitis. All right, what are the symptoms? Symptoms include itching, uh, tearing of one or both eyes, and edema of the eyelids and the periorbital tissues, and the child may appear distracted or irritable. It's very there's like a discomfort that the child will actually feel whenever they have conjunctivitis. Not only from the itching, right? If they're itching a lot, then it's a discomfort. And then also, of course, from the drainage and the crusting, right? For example, you're dealing with an adolescent child, with an adolescent patient, and the adolescent patient has a pink eye. They're very self-conscious, so um, that's one thing to consider. Hyphema. Hyphema is actually very common. This is a presence of blood in the anterior chamber of the eye. Most common cause are ocular injuries. Okay. However, it could be caused from something else. But the main cause is from a blunt um, force, or if there's like a perforating injuries. For example, maybe baseball, right? Maybe the child was playing baseball and the the ball itself actually hit them in the eye. Okay, there's going to be like a presence of blood in the anterior chamber of the eye. Flying objects, right? Maybe they're playing in the park and there's like flying objects and it hit them in the eye. Also could be caused by a forceful coughing and sneezing, right? When they're coughing too much, when they're sneezing too much, then there's a pressure by the eye, in the in the surrounding structures of the eyes. So it could actually cause hyphema. This one appears as a bright red or dark red spot in front of the lower portion of the iris. Treatment. How do we treat it? Oh, by the way, it's common among school age children just because they're very active. They're very, like I said, like I mentioned, they're very competitive, and school age child actually loves to be joining those sports. So that's why it's more common in school age children. Treatment. Bed rest with head of bed elevated 30 to 45 degrees. The reason being is we're trying to decrease the intraocular pressure and the intracranial pressure if there's an associated injury. But yes, we are trying to make sure that we decrease that intraocular pressure. Okay. Topical medications may also be prescribed. However, please remember that ibuprofen and NSAIDs is contraindicated. Reason being is if you see this is a presence of blood. So we're dealing with blood, right? Presence of blood in the anterior chamber of the eye. Giving the patient ibuprofen or an NSAID is actually um, increasing the risk of bleeding. Okay. Condition generally resolves itself without residual problems, so you gotta educate your patient and tell them that after you've ruled out everything else, maybe hypertension, right, or high blood pressure, you ruled out everything, and now you're saying yes, so well, yeah, the doctor said this is hyphema. So you gotta educate the patient and the parents and say the condition actually usually resolves by itself without any residual problems. Retinoblastoma is a type of tumor. Retinoblastoma is a malignant tumor of the retina. Um, Manifestations, it looks like those yellowish with white reflex in the pupil, because the tumor is actually behind the lens. So There's going to be a yellowish white reflex that is seen in the pupil because of a tumor behind the lens. Sometimes we call this also the cat's eye reflex or your leukocoria. This is probably there's like some causes for your retinoblastoma, either maybe hereditary or spontaneous forms. Okay, maybe the child was actually born with the risk or the genes that can cause that retinoblastoma, or maybe it's an spontaneous forms. Chromosome 13 is one. So they said that chromosome 13, there's high risk that with your retinoblastoma there's actually some problems with the chromosome 13. Metastasis is to the unaffected eye is common. What does that mean? It means that maybe it started in the right eye and your left eye is actually unaffected. And yet it could metastasize to the unaffected eye. It's common. Okay. Small tumors are treated by laser photocoagulation. What we're trying to do is actually we're trying to destroy the blood vessel that is actually supplying blood to the tumor. Okay, this condition may be accompanied by loss of vision, strabismus, the one that we just talked about, cross eye, and and in advanced tumor or even pain. Okay. So like I mentioned, small tumors, we can use laser photocoagulation. What you're trying to do is to destroy those blood vessels to supply blood to the tumor. Or for larger tumors, it can be treated with systemic chemotherapy followed by laser therapy or cryotherapy. Enucleation, if you guys remember, enucleation is actually the removal of the eyeball, right? Enucleation is a removal of the eyeball. So that could be if we've tried everything else and the only answer now to treat this retinoblastoma is actually to remove the eyeball. This one is called enucleation. That is your retinoblastoma. You can see on the right side that there's going to be like a yellowish, um, whitish color in the pupil, right? Versus if you look at the picture in the left side, that's the healthy eye. Okay, retinoblastoma is an eye cancer in children. Okay, the nervous system. So the nervous system is the body's communication center. We already know that. It transmits messages to all parts of the body. It records experiences because it goes to your brain, and then your brain is actually the one that's storing it, storing the experiences. Integrates certain stimuli, and then most neurologic disabilities in childhood result from congenital malformation, brain injury, or infection. All right, so let's look at some problem. Neural tube development occurs if it happened during the 3rd to 4th week of life, of fetal life, and then the fusing process is actually very critical. So if there's a failure to fuse, then it may lead to congenital conditions like your spina bifida. If you guys recall spina bifida, where there's like a gap, right, in between, the upper spinal to the bottom of the spinal cord. Okay. So yes, very important for fusing. Its process is actually a critical. All right, when we're dealing with nervous system or we're trying to rule out disorders or disease, or those acute problems that is actually involving the nervous system. So these are the diagnostic testing that we can use for patients. We can do skull x-ray films, your EEG, where is they're actually checking the electrical impulses or activities in the brain, and then CT scan, or what we call CAT scan, and your magnetic resonance imaging, or your MRI. Electromyography is if there's like some muscles that's actually involved, right? Okay, and then we do neurological check because it's very important. Um, this is the way to assess the whole nervous system. Okay. Reflexes in newborns, like we said, that's why I keep telling everyone from first week, from day one, I think, make sure that you know for sure the reflexes of newborns. When do they start, when do they end, right? So that you would know what is normal, what is not normal. For example, is your Babinski reflex, right? We did say that the Babinski reflex is actually present during birth or in newborns, but then within time, maybe in like 12 months, then that reflex should actually be diminished, right? Okay. When you're doing the neurological check, so we are trying to see or monitor some decrease in level of consciousness. Okay, if there is change in LOC or your level of consciousness, then that's a big problem. Okay, when we do neurological check too, we do a finger nose test. How does it work? The examiner is actually going to ask you to put your forefinger on the tip of your nose, and then touch the tip of his finger, and then go back to the nose, and then go back to the finger, both with your right hand and your left hand. Okay, that's what we call a finger nose test. Also, more neurological tests is when we ask the patient to actually balance on one foot, right? That's actually a part of a neurological check, making sure that they can balance on one foot. So the inability to do it is not a good sign for a neurological check. However, always remember that when you do this neurological check, you're actually taking into consideration the age of the child and the milestone of the child that they actually reach already. Like what I'm saying is, if you're gonna do that balance on one foot as a neurological check, you're not gonna ask, you know, maybe a 12-month-old or a 15-month-old child to do it for you, because there's just no way that they can do that, right? The ability to balance on one foot. And then you have the 12 cranial nerves test. If you guys recall, we did this during lab. We tested those um, the 12 cranial nerves test, to see if there's like an intact nervous system. So in page 548, that figure 23.7, that is a picture of your 12 cranial nerves and their functions. Very cool picture. Look at your 1, that's your olfactory for smell, 2 for optic sight, 3 for your oculomotor, which is the dilation of the pupil, and then single vision and opening the eye. 4 is trochlear, which is rotation of eyeball. And for single vision, trigeminal is the sensation of face and chewing. 6 is the abducens, which is the eye movement. And then 7 is your facial. You ask the patient to, wrinkle their forehead, close their eyes, and then, move some facial muscles. And then 8 is acoustic for hearing. 9 is glossopharyngeal for swallowing and taste. 10 is for vagus nerve, which is the for the voice, and then the visceral nerve function. 11 is your spinal accessory for your head rotation and shoulder movement. Okay. All right, state of consciousness, also in the book. Look at page 546 under states of consciousness. Consciousness is the awareness of environmental stimuli, the ability to react to stimuli, and the cognitive ability to respond to the stimuli either verbally or physically in an age-appropriate manner. So, altered level of consciousness is include confusion, delirium, lethargy, stupor, and coma. Okay. The difference, what are the difference? Confusion is a disorientation to time, place, or persons, unable to answer simple or complex questions. Delirium is a disorientation that involving in fear and agitation. Lethargy, sleepy, and difficult to arouse, while a stupor is a deep sleep and responds only to vigorous or painful stimuli. And then coma is the unconscious and unresponsive to any external stimuli. May include posturing. If you guys recall, your decerebrate and your decorticate, right? That falls under coma too. When we're checking the level of consciousness, the state of consciousness, we gotta make sure that we do it in an age appropriate manner, right? You don't expect, for example, you're checking for confusion. You don't expect a 12-month-old child to actually be able to answer, and they're not gonna be able to be oriented to time or place or person, same as with your 15-month old. But if you're talking to like maybe a 6-year-old child or a 7-year-old child, right, then they should have some understanding of maybe a time or a place and person. If they're not able to, then yes, then there's an altered state of consciousness. Okay, what are causes of altered level of consciousness? Um, there's some things that could cause altered LOC. A fall to 60 millimeters per mercury or below of the oxygen, and then a rise of your carbon dioxide, your 40 to above 45 mmHg, low blood pressure because of that low blood flow to the brain causing cerebral hypoxia, fever, 1 degree Fahrenheit rise in fever, it increases the oxygen need by 10%. Drugs, there's some drugs that can actually alter the level of consciousness, right? Your sedatives actually um, make them actually like sleepy or even lethargy. Anti-epileptics too, and then seizures, your postictal state. If you recall, postictal is the state where the patient actually gets very, very lethargic after the seizure, and then your increased intracranial pressure. When there's a high pressure in that brain, then it could cause like some kind of disorientation or altered level of consciousness. Okay, Ray's syndrome. Ray's syndrome is an acute non-inflammatory encephalopathy and hepatopathy that follows a viral infection in children. Okay, there's a relationship between Ray's syndrome and between the use of aspirin during a viral flu or illness that might cause Ray's syndrome. Some studies actually show that it could be genetic metabolic defect that triggers this syndrome, Ray's syndrome, when the stress or maybe a viral illness produces vomiting and hypoglycemia. So what happens with your Ray's syndrome is there's gonna be some problem with the liver cell. Okay, liver cell pathology. This one causes accumulation of ammonia in the body, and when that ammonia actually accumulates in the body, because the liver cannot process it properly, or process it for it to be excreted in the body, then it accumulates, and then it accumulates to a toxic level. Okay, now when that ammonia actually reaches the toxic levels, then you're now going to see some cerebral manifestations. You're going to see some behavioral changes, altered level of consciousness because of the cerebral edema, and that cerebral edema is actually causing increased intracranial pressure. Okay? All right. So in children, effortless vomiting and altered behavior after a viral illness, that's the first manifestation that you will see. And then the liver function blood test will be abnormal because, like I mentioned, the problem is the liver, right? There's going to be an accumulation of ammonia. In infants, diarrhea, hypoglycemia, tachypnea with apneic episodes, seizure that's approximately 1 week after the respiratory illness. And then how do we prevent Ray's syndrome? We prevent it for when we do not use salicylate containing medications during viral illness, right? Like your aspirin, right? We actually do not recommend for patient to use those salicylate while they're during the viral illness, or maybe just right after the viral illness, because it can cause this. Varicella vaccine actually was shown to be helpful against or to prevent Ray's syndrome. Treatment. So for treatment, you want to make sure that we catch it early treatment, so that it doesn't get to the point where it reaches the brain, and then cerebral edema. It could be very harmful to the patient. Reducing intracranial pressure from the cerebral edema, right? If it's edematous, if the brain is having those cerebral edema, then there's going to be an increased intracranial pressure. So the treatment is actually to make sure that we reduce the increased intracranial pressure. Maintaining patent airway is very important too. Maintaining patient airway. Cerebral oxygenation, if we need to give them oxygen based on what the doctor actually ordered. Fluid and electrolyte imbalance from the vomiting, right, from the GI problem, the diarrhea, vomiting, and then frequent vital signs and careful neurological assessments are very important to make sure that we're monitoring the progress of the condition or the disease in the child. Observe signs of bleeding. You gotta observe signs of bleeding. Why? Because in Rey syndrome, the liver is actually affected. Okay, and the liver is actually um, it's actually responsible for those, if you recall those clotting factors, right? There's clotting factors for clotting. So if there's a problem with the liver, then that is actually affected too. So make sure that we observe for the signs of bleeding because there's high risk. This is a short picture of Rey syndrome. So Rey syndrome, once again, is a progressive encephalopathy with hepatic dysfunction. So with Rey syndrome, what are those that are affected? Is your liver and your brain. It starts with a viral illness. In this picture, the example is a varicella or influenza A and B. So it's a viral illness. And while the child actually is having that viral illness, for some reason, the child took aspirin or something that is salicylate base, and then the child is now going to show some symptoms several days after recovery because of the inflammation or the damage to the liver. um, and then it can also cause cerebral edema. With the cerebral edema, you're going to see some altered level of consciousness and behavioral changes. Sepsis. Sepsis is a systemic response to infection with bacteria. Also could be resolved from viral or fungal infections. So this one is a systemic response of the body to infection from pathogens. And then from sepsis, it could actually cause SIRS. We call it SIRS. It's the systemic inflammatory response syndrome because of the accumulation of the toxin and the endotoxin of the bacteria that actually can cause tissue damage. Untreated can lead to septic shock, and when the patient has septic shock, then they could actually go into what we call MODS, or your multi-organ dysfunction syndrome, or even death. So who are at high risk for sepsis? Those people or patients that are immunocompromised. Right? For example, the child that actually have cancer and is going for a chemotherapy drug, then it destroys all those bone marrows, and actually their white blood cell goes down too, putting them at putting them as a immunocompromised. And once they get infected, they don't have that immunity um, to battle that infection, and then they can go into septic shock or sepsis. Neutropenia, exactly what I was just talking about, when the white blood cell goes really down to a dangerous level where they don't have the immunity to actually protect them against infection and sepsis. Okay, manifestations of sepsis. fevers, chills, tachypnea, tachycardia, and neurological signs like lethargy. There's gonna be an abnormal lab results. So the first step actually, when we're trying to rule out sepsis or infection first and then becomes sepsis, is that you're gonna do some labs. Okay, you're gonna call the doctor and get an order for some labs. What are the labs? It could be anything. It could be urine, it could be wound, um, or it could be like a blood culture, right? Blood culture is systemic. So we could do blood culture. And please don't forget that low BP is not diagnosed as shock. Okay. I know usually when we were talking about sepsis or shock in like adults, you're gonna say that it's a low BP and then uh tachycardia, right? So with this one, with children, low BP is not diagnosed as shock. Okay? Hypotension is actually an ominous sign. So for those children that's actually having the low blood pressure, um, while they're trying to rule out those septic shock or sepsis, then it's an ominous sign. Okay, maybe the kid will, if it's left unmanaged, then the kid might go into cold, right? So how do we prevent it from happening? Prevention is immunization, vaccination against bacteria or virus, right? Not bacteria, I'm sorry. Immunization against pneumococcal and those flu vaccines, H influenzae type B and pneumococcal conjugate vaccine. They are recommended for all children 2 months to 4 years of age to prevent this sepsis. Meningitis is an inflammation of the meninges. Meninges are those covering of the brain and the spinal cord. This is caused or could be caused by bacterial or viral or even fungal, but the most common cause is the group B streptococcus. Sometimes what happened with the meningitis is that it invades those meninges indirectly by way of the bloodstream, like a sepsis first, and then it goes and affect those meninges and it becomes meningitis. Bacterial meningitis is often referred to as purulent because of the pus forming that can occur. And then there's also what we call opisthotonos. This is when the child actually is arcing, like there's like an arch. There's gonna be like arching off the back of the muscle because of the muscle contractions. Diagnosis confirmed by examination of the spinal fluid. So your lumbar puncture is going to be needed to make sure or to confirm meningitis. The presence of petechiae may suggest meningococcal infection. So treatment, how do we treat this? The child is placed in droplet isolation until 24 hours after the appropriate antimicrobials have been initiated. Just like your pink eye that we did mention earlier on. So after they start the antibiotic, after 24 hours of taking antibiotic, they could actually be taken off of the isolation, or it's not considered contagious anymore. Neurologic checks as ordered by physician, because remember that this is an inflammation or infection of the covering of the brain and spinal cord. So if this condition actually gets worse, then you're gonna see it with the altered level of consciousness. That's why we're doing neuro checks or neurological checks. Report findings such as weakness of the limbs, speech difficulties, mental confusion, and behavior problems. Also maintain accurate reading or recording of the vital signs and intake and output. You gotta have those baselines of your vital signs, intake and output. How alert is the patient? How oriented is the patient? For you to be able to know, like, is this condition actually, progressing bad, right away. Um, Maintain a quiet environment to help decrease stimuli. More signs and symptoms for the meningitis. There will be a severe headache, drowsiness, maybe delirium, irritability, restlessness, fever, vomiting, and this stiffness of the neck. Please remember, could be a sign of your meningitis is the what we call nuchal rigidity, is the stiffness of the neck. High pitched cry in infants, and then seizures are common, and coma may even occur. Encephalitis. Encephalitis is the inflammation of the brain itself, the brain. Also known as encephalomyelitis when the spinal cord is actually infected too. So, encephalitis for inflammation of the brain. And if the spinal cord is actually infected, then it's encephalomyelitis. Encephalitis may occur as a complication of childhood diseases such as your measles, your mumps, or even chickenpox. So, in order to help with this um, problem, we gotta make sure that we're actually advocating for vaccinations or immunizations, okay? Because those childhood diseases, even though it's not actually um, fatal, the disease itself, but if it actually causes some other things that could be harmful, like your encephalitis that started actually from mumps, right? Then that's not good. So you gotta make sure that you're actually educating for immunization, okay? That it's recommended. Um, well, for them to be taking those vaccinations. Okay. Fatalities and residual effects are higher among infants than among other children. There's a delay in speech, motor, mental, and disabilities, and permanent brain damage that can be result from the encephalitis. Treatment. We only do supportive and provide relief from specific symptoms. We do not have treatment, right, for your encephalitis, but it's mostly supportive and providing relief from the specific symptoms. Okay, symptoms result from the CNS response to the irritation. So headache that is followed by drowsiness, may proceed to even comatose, coma, and then convulsions are seen, especially in infants, fever, cramps, abdominal pain, vomiting, your nuchal rigidity, delirium, muscle twitching, and abnormal eye movements. Okay. Um, So treatment, we do only supportive and we provide relief from specific symptoms. However, we can maybe give them some sedatives and antipyretics. Seizure precautions also is very important. Seizure seizure precautions are taken. Provide for adequate fluid and nutrition, and supplemental oxygen may be needed. Okay, brain tumors. Second most type of neoplasm in children. Etiology is usually unknown, right? This most occur in lower part of the brain and is common in school-age children. Signs and symptoms are basically actually um, related to the location and size of the tumor. So whatever is affected, then that's how you're gonna see the signs and symptoms. Diagnosis is made by clinical presentation, laboratory tests, head CT or MRI, EEG, and then surgical intervention in some cases. But that's going to be like a brain um, surgery or manipulation. So you they might even try like chemotherapy first and then radiation and see if that works, so that surgical intervention should be the last one. Right. While we're talking about surgical intervention, so same thing when you're gonna do your preoperative and postoperative monitoring for a patient, especially that this is a brain tumor, so it's like a brain surgery, right? So you gotta be very careful. Preoperative and post-op is highly recommended. So we need to prevent you know um, contamination or infection, so you make sure as nurses you do hand washing or hand hygiene before and after. And then if your patient is actually going for a radiation, there will be marks, like radiation chemo will have marks and are not supposed to be washed off. Okay. Okay, types of seizures. So you have your febrile seizure, and then we have those epilepsy, and then classified as generalized and partial. Okay. Febrile seizures. So febrile seizures are those condition that's actually common in children between 6 months and 5 years of age. They said there may be a genetic predisposition explaining why children in the same family usually have this. Um, what happens with febrile seizure is that the child is going to have a fever, right? There's a rapid rise in temperature, and the seizure actually occurs in response to that change of temperature. So that's a febrile seizure. Okay. Um, okay, seizure diagnosis and treatment. How do we diagnose and how do we treat? So it depends on what type, right? Determining type, site, or cause. Um, Maybe it's a tumor that is causing the seizure. Maybe it's a fever that is causing the seizure, right? So determining type, site, or cause. Multiple diagnostic techniques can be used. We can use CT scan or MRI or the EEG to see those electrical yeah, electrical activity in the brain is what it's gonna check if it's normal or not. Laboratory tests to rule out poisoning or electrolyte abnormalities. We did just discuss that some reasons. I mean, seizure could be caused by some other reasons too. That is actually environmental. Drug of choice depends on the type of the seizure. Diet changes may be needed for patients who do not respond well with anticonvulsants. Cerebral palsy is a term that's used to describe a word of non-progressive motor disorders is caused by a lesion in the various motor centers of the developing fetal brain. There will be types of the cerebral palsy, which is spastic, athetioid, ataxic, and mixed. What manifestations will we see? It varies with each child. Okay, it varies with each child. This may range, or manifestations may range from mild to severe, or there may be some intellectual and developmental disabilities that's could be sometimes seen. So, suspected during infancy if number one, there are feeding problems. Okay. There's convulsions that's not associated with high fevers. There's a developmental milestones that are not being achieved at expected age level. Those are things that could suggest, oh, need testing is now more testing is needed to confirm cerebral palsy. Okay, elements that involve in mental functioning for the cognitive impairment, your level of consciousness, your thought processes, and then expressive languages. Okay. Intellectual impairment, um, this one is actually, according to the American Association on Intellectual and Developmental Disabilities, your AAIDT, mild or severe. This is actually an IQ that is below 70. Okay. Um, there's going to be limitations in at least two of the following: how the patient communicate, self-care, home living, social skills, community use, self-direction, health and safety, functional academics, and leisure and work. Some types, some causes of intellectual impairment during the neonatal period. If you guys can recall, we did talk about PKU, your phenylketonuria, and then your hypothyroidism, fetal alcohol syndrome, Down syndrome, malformations of the brain, maternal injections, or birth injuries or anorexia during or shortly after delivery. For heredity, during childhood, maybe they had the meningitis, encephalitis, and the lead poisoning, neoplasms, and or if they're living in a physically or emotionally deprived environment. Okay, approach to intellectually impaired child. We teach parents to provide experiences that the child can be successful in, concentrate on the strengths and not the weakness. Constant failure can cause child to become angry, which can cloud the problem and interfere with successful therapy. Also provide emotional support. Okay, head injuries. This is the major cause of death in children older than 1 year of age. Um, A concussion is a temporary disturbance of the brain that is usually followed by a period of unconsciousness. A child's response to a head injury may differ from that of an adult. So loss of consciousness may not be evident, right? Loss of consciousness may not be evident, but maybe there will be a change in behavior of the patient, or there will be a sleep problem, cognition imbalance. Problem with cognition and balance may even occur. Okay, like for example, you ask a child to stand on one foot with the eyes closed. Maybe this, you're talking about a child that can actually physically do this task. However, today, right, you ask the patient and then the patient cannot actually stand on one foot and eye closed. So you will think about something that's going on neurologically. Hypoxia, increased intracranial pressure, cerebral edema, and infection can occur within a few days of a head injury. So that's why those patients that actually had a head injury, for example, maybe a child that had maybe was that had a motor vehicular accident, for example, right? And then there's the head injury. So in the first 24 hours or in the first few hours, that's very critical. That's the time where you gotta monitor the oxygen saturation of the patient, the vital signs of the patient, monitor them for increased intracranial pressure signs and symptoms, checking for signs and symptoms of the cerebral edema, right? Okay, so that's why they're being monitored for at least 24 hours after the head injury to make sure that there's no signs and symptoms of increased intracranial pressure or cerebral edema even. Okay, hypoxia causes the brain to need increased energy, which increases the cerebral blood flow. And if there's an increased blood flow, then it causes cerebral edema. However, if intracranial pressure rises too high, then cerebral perfusion diminishes and the brain damage or even death will follow. All right, signs of post-concussion syndrome. So, post-concussion syndrome, you'll monitor the patient for headache, fatigue, photophobia, and disturbed thinking. Like I just said, after they have this head injury or maybe it's just a concussion, then we're gonna monitor the patient for the next few hours, 24 hours, maybe longer if the doctor orders it. But we monitor them for these signs and symptoms because these signs and symptoms, there are cases where it's not gonna show up right away. It's gonna show up hours after the head injury or the concussion. So that's why we're monitoring them. Signs of post-concussion syndrome is your headache, fatigue, photophobia, and disturbed thinking. Shaken baby syndrome, very important for us to talk about. Shaken baby syndromes are those infants that are roughly shaken. Okay, roughly shaken can sustain retinal subarachnoid and yes, subdural hemorrhage in the brain. Okay, even cervical spine injuries. You can cause those things by doing the shaken baby syndrome. It can even result in permanent brain injury or death. So, what is shaken baby syndrome? Shaken baby syndrome is when you're holding a baby and maybe just an example, and the baby won't stop crying. Okay, and then the mother that's holding the baby is actually burnt out, for example. Then what she's gonna do is, like, she's gonna shake the baby, for maybe she's saying, oh my god, stop crying, stop crying, stop crying. So that would be a shaken baby syndrome. Okay, or another example is an infant or a little baby that actually is being shaken because the adult that's holding the baby is actually in a trampoline, right? So that could cause actually shaken baby syndrome as well. Okay, but the problem is that it can result in permanent brain injury, even death. Okay, even death. So symptoms of this shaken baby syndrome, symptoms can include headache that's manifested as fuzziness in a toddler, drowsiness, blurred vision, vomiting, dyspnea, and in severe cases, child may completely be unconscious. Right? And it's not a good sign. Okay. All right. Observing signs for observing child for signs of intracranial pressure. There's four components of a cranial or neurologic check. That's your level of consciousness, pupil and eye movement, and then vital signs and the motor activity. Nursing care of a brain injured child. So the goal here is actually to monitor, and then interventions if there's actually a problem, right? For head injuries or brain injured child. So you're gonna monitor very, very thoroughly as the nurse is taking care of a brain injured child. There will be subtle clues to change. There will be subtle clues that can be easily missed, right? Can be missed unless the nurse performs aggressive assessment in looking for them. And then the lack of child's ability to communicate and to cooperate poses a challenge in the neurologic assessment of infants, but knowledge of normal growth and development aids the nurse in evaluating the status of the patient. That's why it's very important to know the normal growth and development of the child, or not normal, like um, the baseline, okay, of the child. Neurological monitoring of infants and children. So you're gonna look for pain stimuli response if we need to use those um, pain chart that we did talk about during class, and it's in the book. Those flag, those smiley faces, right? Level of consciousness, like in adults, if you're monitoring the neurological status of a child, there will be changes in the level of consciousness. There will be changes in how alert and how responsive the patient is, and that would be like a sign for a neurological issue. Arousal awareness, cranial nerve response. You're gonna do those things that we actually do for to test the cranial nerves. Motor response, posturing, pupil response of the eyes, bulging fontanelles, right? That's an increased intracranial pressure, scalp vein distension, ataxia, spasticity of lower extremities, and more or tonic neck with withdrawal reflexes. Okay, near drowning. Accidental or near drowning is the fourth leading cause of death in children younger than 19 years of age. Near drowning is defined as those survival that beyond 24 hours after submersion. Okay, so submersion for more than 10 minutes with failure to regain consciousness at the scene or within 24 hours is an ominous sign and indicates severe neurologic deficits if the child survives. Okay, so that is the number that we have to remember, is if it's a submersion that is more than 10 minutes with failure to regain consciousness at the scene, or 24 hours, within 24 hours, that's not a good sign, right? That's an ominous sign, and this one indicates severe neurologic deficits even if the child actually survives. Priorities include immediate treatment of hypoxia, right? That's the main problem when there's a near drowning or drowning. Hypoxia, the oxygen is not actually going to the lungs, and it's not actually helping also with the oxygenation of the brain, right? So that's one of the priority is for immediate treatment is hypoxia is number one. Number two is aspiration, right? Aspiration, very straightforward. And then number three is your hypothermia. Okay, when the core body actually goes really low to a dangerous level. Okay. And then CNS injury remains the major cause of death or long-term disability. And that's it for this chapter.